Hi everyone, my name is Manasi Jaiman and I'm a pediatric endocrinologist. Today I want to talk to you about the first day that you're diagnosed with type 1 diabetes or someone that you know or your child is diagnosed with type 1 diabetes, what to expect. There I am on the screen. It's my cartoon version, my childhood dreams coming alive. One thing I want to make sure you know, as we go through this, there's a lot of puzzle pieces. It's very overwhelming when you're first diagnosed, but it does come together, and it comes together slowly, and everyone has their own timeline. However, there are a few things you should know to get you through this. You are not alone. That's first and foremost thing I want you to know. Also, lean on others for help. And it's okay to be scared. It's okay to be overwhelmed, and it's okay to be angry. It's okay to have all of those feelings. And there's absolutely nothing you could have done to prevent this. And lastly, you got this. So let me tell you a little bit about all of these. You are not alone. Absolutely not. There's an entire community of patients, of parents, of your team that you're going to be introduced to that will help you and support you through this process. As you learn, as you grow, yes, things aren't going to be the way they used to be, but you will eventually find that new normal. And you'll continue to have that support because of the amount of resources that are there. So always lean on others for help. That's how you're going to get through this. And again, it's okay to have these feelings. Everyone receives this differently, especially as a parent. You're scared for your child. You're scared for your life. You're scared about what they're going to do, how they're going to get through this, depending on how old they are, how they're going to feel about a sudden change in their lifestyle. But also remember this, no matter what, don't go back and say, could I have done this differently? Could I have given them something else to eat? Because there's absolutely nothing you could have done that is different. And lastly, you got this. What do I mean by that? Every patient that I've ever seen, every parent that I've ever talked to, I have told them this one thing: wait a month. From the time you're diagnosed to the month out, you will learn so much. It's incredibly hard. It's incredibly, it's an uphill battle that you have to get through, but you will get through it. You have to lean on others. You have to make sure that you understand that it's going to take time. And once you do that, in 1 month, I guarantee you're going to come back to your endocrinologist and say, well, actually, this is best for my child. This works better. And that conversation will empower you and make you feel like you can actually do this, and you do have this. There I am again. So let's talk about what is diabetes. This is more focused on day one, getting to know the basics. So let's start with the pancreas. The pancreas here is located right behind your stomach, a little bit below your rib cage. It's responsible mostly for digestive enzymes to help you process things you eat. Also, one of the most important things with type 1 diabetes is it makes insulin. So again, here's the pancreas, where it's located. It's part of the endocrine system. All you have to know here is that it's a small part of what the pancreas does, but it's a huge part of what it means to you and your family. So within the pancreas, what do we have? We have a group of cells that are called islets, little islands of cells that make insulin and glucagon and some other hormones that we're not going to focus on today. Insulin is made by cells called beta cells. Insulin, when you eat something, makes your blood sugar go up. Insulin is released to make that blood sugar go down. All right, another hormone that's produced by the pancreas, a group of cells, alpha cells, makes glucagon, and it helps your blood sugar go up when it's trending low. However, one of the main things to focus on is insulin today. Insulin allows what you eat for energy, so carbohydrates broken down into usable products for energy, are entered into a cell only through basically insulin acting like a key. And without insulin, that energy doesn't go to your cells. So type 1 diabetes, what happens? So again, on the left, you're going to see a healthy pancreas. And then again, those groups of cells you'll see inside there, they're beta cells. On the left side, they look healthy and robust. On the right side, what's happening is that they're being destroyed. Now, type 1 diabetes is what you will hear as an autoimmune disease. It means that your defensive cells in your body are attacking your own cells. And we don't always know exactly why it's happening, but we know that there is a trigger that causes eventually those cells to be destroyed by your own defense mechanism. And they're only targeting those beta cells. So what does that look like? I often get questions from families of when did this happen? How do we know that it was going to happen? There's no telling. There's no specific sign that you can say, oh, my kid's going to get type 1 diabetes. But let's talk about what that could look like. So look at this graph. And I did draw this. So I apologize for my terrible handwriting. Remember, I am a doctor. So the fact that I can even read it is a pretty big deal. So on the y-axis, you're seeing insulin-producing cells. And on the x-axis, over time, so just a period of time. We don't know always how long that is for people. It could be weeks, could be months, could be years. So right here, dotted line. Green is normal insulin. Dotted line is some trigger. So for a while, you're making normal insulin. Maybe in that pocket of time, there's some genetic factors related, but still, you haven't developed type 1 diabetes. But that trigger happens. Could be a virus. It could be stress of some kind. That triggers your body to start attacking those cells. And now you start making less insulin, and you're making less and less insulin, but your body's still managing to keep up until you reach a point where it just can't. And that's when you start having symptoms. So many of you who have had kids who are diagnosed with type 1 diabetes, maybe they came with terrible stomach aches, they were peeing all the time, they were drinking tons and tons of water, and you couldn't figure out why. Well, those are some of the symptoms that are often the first symptoms that they'll have. And once those symptoms start, that means that your body just does not have enough insulin to use the energy that it needs. Now, before we move on, I want to touch base on type 2 diabetes. They both have the same term, diabetes, but they're inherently very, very different. Type 1, beta cells are being destroyed, so you're just not making the insulin that you need. Now, type 2, insulin resistance. So pancreas is making lots of insulin, but the problem is that the cells aren't being able to take it in. There's some form of resistance there. I'm not going too much into detail. Just understand that even though you hear type 1 and type 2 diabetes, they're absolutely very different. And the amount that you have to learn for someone who has type 1 diabetes is so much more than someone with type 2 at the very beginning stages. And just remember that. So let's focus on management. What do I want every parent, every family member to learn for their child as they're being diagnosed? A, how to take their blood sugar. It's so important to know how to do that, what meter you're going to use. And when I see parents for the first time, I make sure I spend hours. And this is day 1, but day 1 extends out to about a week, essentially, because you are learning all of these things for the first time. It's your first exposure. There's so much going on, but there's just 3 basic things that you have to know in order to survive day by day as you're learning more and more. So first is taking the blood sugar, and that's through these meters. Not going into specific meters today, but I will show you what's coming up. Next, insulin, how to draw up insulin. Now, there's so many other things that you're going to learn about: pumps, smart pens, easier ways to deliver insulin. But for me, it's a basic skill you have to know is how to drop insulin from a vial into a syringe. Because most of the other things, the way we dose is based on technology. And as we know, technology doesn't always work. In fact, as I was making this presentation, battery ran out of here. Did we know that was going to happen? No. But it did, and I had to change it out. But I had to rely on the fact that I could have another tool available for me to be able to make these slides move forward, right? Same thing with technology that involves type 1 diabetes. You never know if a part's going to be broken, not working, and you need to go back to something very basic, as maybe Eric, who's behind the screen, touching the keyboard itself to move this slide forward. So again, important to understand the basics. And then 3, how to address when your blood sugar is going low. The biggest question I get, I guess, every time when I see a family and a patient who's been diagnosed recently, how can I prevent these lows? How will I know? Well, one thing I always say, there's so much out there now to allow you to take your blood sugar so frequently that you'll always get a trigger when the blood sugar is going low. But again, before we get to that, you need to know just basics in case you don't have that available or it's not working. So how to give carbs, how much to give, how much to give based on your child's age. And then emergency use glucagon. Again, it's very similar to insulin in terms of how you inject, how you draw up, but it's the opposite of what insulin does. It brings your blood sugar up. So let's go into insulin dosing. Insulin dosing, you'll see, you're going to learn this, you're going to be experts at this, but it's important to understand what types of insulin because it's not all the same. Now, this is going to be very basic, but I want to make sure you understand. Again, apologies for my terrible handwriting, but I love this graph so much because this is the one thing I've used since the minute I went into endocrinology fellowship. This is how I teach families. I'm a visual person, so hopefully this helps you. So on the y-axis, you see blood sugar. And on the x-axis, let's talk about a full day of breakfast, of lunch, and of dinner. In the bottom, the red means you're in the low range for blood sugar. Green, it's in the right range, where you're happy to stay in. And yellow, too high. Now, you will learn what that green range is. For right now, I'll just tell you it's 70 to 180 milligrams per deciliter. But all of these numbers you will be provided with, and you should be provided with new numbers as you move forward in order to how to dose insulin as well. I'm not getting into details because it is overwhelming. It is a lot of math. I promise you will get through this, but let's get through this first part. So imagine your blood sugar. What do you want it to look like? Pretty steady. So if you didn't eat at all, if your child didn't eat at all, and you wanted to keep your blood sugar at a steady state for a long period of time, and this is their baseline, what do you use? Baseline, basal, remember that, or long-acting. That's the type of insulin you're using, long-acting. So over time, keeps you at your baseline. That's the best way to remember that. What if you are eating? All right, so you've established a baseline. You wake up, you're at your baseline. Say for your child, it's 100, 120. You stay at that baseline. But then you're hungry, you're going to eat. Your child's going to eat maybe cereal for the morning, and then it's going to have lunch and dinner. And you have these short bursts where your blood sugar spikes because you've eaten carbohydrates and you need to dose insulin. What brings that level down? Right there. What makes it quickly go down in a short term? Short-acting insulin. It's the best way to remember it. It's a quick, short response. So short-acting, and then what's at the baseline is the long-acting that keeps it at that baseline or basal insulin. Now, checking and dosing insulin. Another question I get often is, how often do I check blood sugar levels? Initially, and this can change depending on how old your child is and what their needs are at that time. So usually this is how we start, and there could be probably more at the beginning, first few weeks, in fact, until you get used to their rhythm. We have so many other ways, like I said, of checking blood sugar levels, including continuous glucose monitors, which I will touch on at the end of this. But if you're doing just finger sticks where you're taking blood sugar and using a meter, we recommend usually when you wake up or your child wakes up in a fasting state before all meals or snacks, before bedtime, and then at 2 a.m. And that 2 a.m. is interesting because what we are trying to do is make sure that you understand what your child's routine is at night. So if they're going to bed early like 7 or 8 or late like my daughter at 9, 9:30 sometimes, she puts up a fight, then that 2 a.m., maybe 3 a.m. But it's to see if you actually go low, if your child goes low, or if they're going high. And do we need to change that baseline insulin? Remember, long acting. So overnight, that's what keeps keeping the blood sugar at that baseline. Do we need to change it at 2 a.m.? Possibly. But more numbers, the better. So how much do I dose? Well, we touched base on short acting and long acting. Let's talk about short acting. Insulin dosing to correct high blood sugars back to baseline is known as the correction factor. So you're at your baseline and you were at your baseline, but now you're like 50, 60 milligrams per deciliter above that baseline. How do you get back down? And this is without eating. That's correction factor. That's a number that you'll receive. Now, maybe later on in another podcast, or I can reference some for you guys as well, learn how to do these calculations. But right now, I just want you to focus on what they actually do. And then insulin dosing to cover carbs eaten is known as carb ratio. Again, you'll get that number. And basically what you do is you say, I'm going to eat, a slice of pizza. I'm going to eat, 4 bananas, whatever it is. But there's carbs in all of that. And there's resources that allow you to understand how many carbs are in all the food your child eats. And based on that, you'll know how much to dose. And that is called carb ratio. Carb ratio is a little easier to understand just because it's based on carbs. Correction factor, just remember, you're correcting it back down to a baseline that you've established for your child. Now, long-acting, usually it's given once daily. And that dose is decided on by your endocrinologist, your provider, your child's pediatrician, just depends on who's following their care. Now, one thing that's very important that when I started training, which I promise you wasn't that long ago, but it was a while ago, is there are so many more apps available on smartphones and smart devices to help you with calculations and also help you understand carbs, what are in different meals, what are in different foods, and then you can plug that into these apps and it'll dose for you. It'll tell you exactly how much insulin you need to give. However, one important thing on day 1, week 1, is to understand how to do it yourself, just in case technology is not always around. And it's always good to have that backup. And there's more suggestions coming towards the end, but I wanted to hold off on that. There's so much out there and I'm excited to show that to you, but I also want to make sure that you understand the basics here. So another thing I always go over with my families is low blood sugar, which is actually the most important thing out of leaving you. Remember, I told you 3 things: how to test, insulin dosing, and then making sure how to check for lows and how to address those. So lows. Kids act very differently depending on how old they are when they actually have a low blood sugar or low glucose level, as you will hear. A blood sugar less than 70 milligrams per deciliter is considered low. What are the symptoms? This is a funny cartoon here, but it actually pretty much reminds me of my daughter on a daily basis, especially just the faces she makes and when she is hangry, if you will. But kids specifically with type 1 diabetes have a very distinct way, and it's often missed because it could be literally any other kid who's experiencing a bad day or having a tantrum of any kind, but you won't be able to pick up on it. So remember, the thing you want to make sure is you test, test, and test. If you are even questioning it once, twice, 3 times, test. Some of the symptoms that I've seen for patients when they come in is they're just having a belly ache, or they're irritable for a long period of time, or they don't want to talk, and they're usually really, really active, but they're very fatigued, and that's parents will say, well, they were drinking a lot, they were peeing a lot, but I thought they were peeing a lot because they were drinking a lot. But then what was really crazy was that they complained about a headache, and I don't even know if they know what a headache is because they're so young. And then they'll say, well, also they just have been really sleepy and tired, and I've gotten calls from school that they're falling asleep. So those are some of the things to keep track of. But if you're ever worried that they're going low, go ahead and test. Now, some of the exceptions here when it comes to diagnosis, the first day, the first week, and it's all dependent on age, is how we consider low blood sugar. In order to make sure that the dosing is right, because we're all learning together what your child absolutely needs in terms of insulin, is that low blood sugar level, instead of making it 70, we'll put it up a little to give you a little bit of a buffer so you don't overshoot, and there's always some space. Because one thing is we don't want it to go too low early in diagnosis. It's really important to have that buffer. And so instead of say 70, sometimes for patients, I'll do 100 milligrams per deciliter, maybe even 125, sometimes even 150, just to ensure that they don't overshoot. And as we learn, and it's a daily learning process, it's a meal by meal even, that you're learning what that baseline is, and then what's the low threshold for you and your child. So treatment of lows, another very important thing. If you take nothing out of this, I want you to focus on exactly how to treat your child's lows. So what do you need? You need sugar that can be quickly absorbed. And then once you give the sugar-containing substance, so you'll see on the bottom, you retest your child's blood sugar level. And if it's still low, so based on what we've established as that low, 70, 120, whatever it is, you give more. But as you're going through this process, especially early on, call your doctor. Call the on-call doctor. Call the resource that you have been given when these things happen. That first day, that first week, having that is so important. So let's look at some of the examples. Under 5 years of age, you want to give about 5 to 10 grams of carbs. What is that? If you think about it, it's a very small amount, but for someone under 5, it's appropriate. It's either a quick half cup of juice, which is approximately about 4 ounces, 2 to 4 ounces should do. 2 teaspoons of cake gel icing. I know it sounds disgusting, but that literally is such a quick acting carb. The other thing I've actually asked parents to usually keep in their bag is, if you remember Pixie sticks, you have like that sugar substance, and they make versions of that are specifically geared towards type 1 diabetes, but you can just get a Pixie stick and give 2 of those. And then, or 3/4 cup of milk. Now, a lot of people don't have milk just on hand if they're out. So something I would say is always carry something like that's easy to give to a small child. These Pixie sticks are amazing. Then 5 to 10-year-old, 10 to 15 grams of carbs. So again, just a little bit more of some of the things we've talked about. It does say 4 to 5 ounces of regular soda. I will say this, that unless it's absolutely necessary, that's all you have, do it. Soda is necessarily not the best first choice, but it has sugar, and in times like this, doesn't matter, get it to them. And then glucose tablets, because now they're able to bite into those, swallow those, and then Skittles. In fact, you know, the care packages that our families usually receive will have some Pixie sticks or Skittles because those are easy to just carry with you. And then half cup of juice if you're around some place where you can get juice. Teenagers, actually very similar to the 5 to 10-year-olds, but just more. So teenagers are just over 10 years of age, 15 grams of carbs. And you can see it's very similar to the previous 5 to 10-year-old group. But something that's accessible. And honestly, this is such a limited list. You will know exactly what's easy for you, what to carry, and let that be what guides you. This is just the initial steps to take. So I'm going to touch base on high blood sugar, which is, again, high blood glucose, hyperglycemia. What are some of the symptoms? Now, there's some overlapping symptoms here when someone's low versus someone's high. So you have stomach pain, you could have irritability, and those two are the overlaps. There's also multiple things. Sometimes you don't even know. They're just a bellyache, which I know many kids all the time. My own kid, belly aches all the time. How would you know how to be careful about understanding if it's a low or a high? Take the blood sugar level. And hopefully if they're on a continuous glucose monitor, it won't matter. You'll know, you'll have an alert. But as you're learning these first skill sets, take the blood sugar just to be 100% sure which direction they're going. Now, blood sugar greater than 180 is generally considered a high. And I've already talked about the symptoms, but let's talk about what are the exceptions, especially that first day, that first week. Depending on age, a high blood sugar is kept at a higher value. And we keep in mind the age, of course, and what's reasonable here. But even though it's greater than 180, we even say, okay, if they're between, say, their low now is 100 and 100, then their high can be 200 to 250. Even if you get it down to 250, especially these young kids where you don't know exactly how much insulin they're going to need, we just try to keep everything having a buffer to limit how low you get. That's the first thing we want to always prevent. And if you're unsure, like I said, always call the on-call doctor. That is exactly the resource that's available for you, and very important to have that established early on. Now, the treatment is insulin, but then the most important thing is to understand why they're going high. Is something wrong with the insulin? Something wrong with dosing? Did they not get enough? And if you're on a pump, something wrong with the pump. So let's move on. I want to touch base on this, but I think I've already said so much. I know in your mind, it's, again, a ton of puzzle pieces, and I've probably gone through like 3 or 4 puzzle pieces at this point. And there's an entire puzzle you're going to have to solve. Over the month, you will understand. But this is a part of it that's going to make your life so much easier. There are so many things that have come out for diabetes technology in the last 5 to 10 years, and they're just continuing to improve almost weekly now. We're hearing new things that are approved by the FDA because of how accurate they are in the market, how accurate they are for blood sugar monitoring, how accurate they are in terms of dosing, how different things talk to each other to allow for automated dosing, and it's an exciting time. What I want you to remember is that there is a lot. There's a lot that'll help make your life easier. It sucks having type 1 diabetes. There's no way around it. But there's things that can ease the burden, even a little. And that includes better meters, continuous glucose monitors, which basically take your child's blood sugar every 5 minutes and inform you if they're trending high, trending low, and they even give you alarms. There's pumps that you can now dose through your phone or through a separate remote, essentially, that you can carry with you while your child sleeps. Because what I hear all the time, especially early on, is I couldn't sleep all night because I didn't know if they were going to go low. And before we had all of these accurate technologies available to us, parents were staying up all night just testing. Kids would be asleep and just testing, pricking their finger and testing. So the goal is that you learn these basic skills, but also quickly transition to some of these technologies that are available to allow you to understand that the burden doesn't have to be as high. And then, of course, I did talk about apps for diabetes management. There are so many. So this is just, 25% of what's available in general, maybe even 15%. Honestly, I don't know all of them either because there's so many new ones coming around. But a few things to remember, and I'm going to get to this on the next one, is there's an entire community of parents, of patients, of advocacy groups outside of even the hospital or the clinic that you're involved in that can help you and guide you to figure out what's best for what you need, for your child, for your life. Different diabetes management apps that'll help you understand how to dose, how to calculate, how to eat healthy, how to calculate carbs, how to prevent, how to be in clinical trials. And then also, what are the other community conversations going on? This is so important, that those resources, and to understand that. And don't worry, first, it's learn the basic skills and then get incorporated in all of this, because what's important is to understand that first point I made is that you are not alone. And then learn more about T1D. TCOYD, I'm telling you, if they were available for these videos that they have now, when I was starting my endocrinology fellowship, it would have been a blessing. I asked so many people, like, where is something that we could give to patients and they can understand in a meaningful way, to understand in a very basic way, and that's fun to understand. For parents, how do you engage with others in the community? If you want to know more, there's so many amazing videos that now I actually send to my endocrinology group back in Boston all the time. I send them all of these videos because they're so helpful. Go to this website. I'm telling you, you've probably already seen them, and I'm just the next in line of all the incredible videos that are out there. But there's so many resources available. Start here. And then, of course, I talked about the resources in the communities. I have never seen a community as strong as I have, as the patients and the parents and the families of the type 1 community. It is incredible what they offer, the resources, the companionship. It's the burden that they carry together. And it is exactly why I'm here talking to you about this, because it is so strong. So there's a huge list, but remember, start with TCOYD. They have all of these on there as well. But then these websites here, go on there, see what works for you, talk to people, understand what's going to work for you, your lifestyle, your child, and how to get them engaged. I also want to put a plug in for young kids, teenagers. There's camps that are made specific for patients who have type 1 diabetes. They come together. They're doing camp things, but they're doing it in a setting where they all have type 1 diabetes. And it's a commonality that strengthens their relationship with the other people around them, makes them feel stronger, and makes them understand that this is a normal that everyone in that community lives. And one thing, I'm going to walk you through this, that I don't want you to forget, is that we're always going to be there as a medical community for you. But it's beyond that. It's the resources, it's the people that you engage with and surround yourself with, because you are not alone. Your kids are not alone. And those puzzle pieces will eventually fall together. It will make sense. It will take time. It will be hard, but you can do this. And your kids, they can do whatever they want. They will continue to play. They will continue to have activities. They will continue to be engaged in anything that they were before they were diagnosed. Just, it's going to take time. It's going to be a new way of doing things. But at the end of the day, what you imagine for them when they grow up is continue imagining that, because it's all still possible, and we're here to help.